guys, welcome to your health promotion and levels of prevention lecture. We're going to be talking about things that relate to health promotion and also identifying people at risk for having health disparities. So looking at this slide right here, we're going to start by talking about the World Health Organization, who always sets goals for health and wellness amongst the community. Some of the things you can see here, there's different things that look at prioritizing health needs, maybe addressing the causes, maybe looking at the quality of education, health literacy, things like that. You can also see medications and food, um, healthy diets, things like that. And so you can kind of look at these things and see the different areas that the World Health Organization identifies as needing attention when promoting health and are really at the forefront of all the efforts that are made to have health. So let's look at the difference between health, illness, and wellness. So health is a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. So basically, guys, health is, you might say you're healthy, but it's not just that you're not sick or that you don't have a disease, but do you truly have a state or a feeling of complete physical, mental, and social well-being? That's really the definition of health. Illness is the unique response of a person to a disease, an abnormal process involving changed level of functioning. And then wellness is an active state of being healthy by living a lifestyle promoting good physical, mental, and emotional health. Okay, so those are the three differences there. Let's look at illness a little closer. So we have two different types of illnesses that your book discusses. It discusses acute illness and chronic illness. So acute illness focuses on rapid onset of symptoms, lasts only a relatively short time. Some examples might be something like appendicitis, pneumonia, diarrhea, or the common cold. That would be considered acute illness. Which is an example of an acute illness? Would it be A, diabetes, B, rheumatoid arthritis, C, pneumonia, or D, osteoporosis? All right, if you said C, pneumonia, you're absolutely correct. C was the example of an acute illness. Remember, that's going to have a rapid onset, lasts only a relatively short time. The rest are considered chronic illnesses that can cause permanent change. Okay? All right. Moving on, we have chronic illness now. This is a broad term that encompasses many different physical and mental alterations in health, usually has a slower onset and may have periods of remission and exacerbation. Some examples of that would be diabetes, lung disease, arthritis, or lupus. So if you think about something like asthma as well, asthma might have a period of remission and then exacerbation, something that exacerbates the patient's asthma. So a chronic illness is going to be something that's slower, onset, might progress, and has differences in whether it's, active or maybe in remission. Characteristics of chronic illness, it is a permanent change, causes or is caused by irreversible alterations in normal anatomy and physiology, requires special education, and obviously requires longer period of care or support, maybe even requiring rehabilitation services, okay? And then just so you guys know, a patient may have an acute illness, a chronic illness, or both at the same time. For example, an adult with diabetes, which is a chronic illness, they may also have an acute episode of severely low blood sugar. Okay, so that would be, something where they can have acute or chronic. Also, maybe somebody with, asthma gets pneumonia. So, you can see that chronic and acute illness together. So let's answer this question. As client is admitted to the hospital with abrupt symptoms of increasing shortness of breath, fever, and a productive cough with green sputum. Upon further exam, the client is diagnosed with COPD, exacerbation. The nurse identifies this as which type of illness? Okay, so let's see the answer. A, terminal, B, contagious, C, acute, or D, chronic? Let's see, guys. So this would actually be chronic illness. It's a broad term that encompasses many different physical and mental alterations in health with one or more of the following characteristics. Remember, the patient did have COPD. Let's go back really quick. The patient did have COPD. However, right now they have abrupt symptoms of those things, the shortness of breath, the fever, productive cough with green sputum. So because they have the COPD and they're having an exacerbation of that, that would be considered a chronic illness. A homeless client has been brought to the emergency department by ambulance after being found unresponsive outside of a mall. The client is known to the ED staff as having bipolar disorder, and an assessment reveals likely cellulitis on his left ankle. He is febrile with a productive cough, and the care team suspects pneumonia. A sputum culture for TB has been obtained and sent to the lab. Which of the following aspects of the client's medical condition would be considered acute versus chronic? So if you're looking at this, the chronic would be the bipolar disorder, right? And then we see that there's an assessment that reveals, cellulitis, which would be more acute, and that's because that's, characterized by his being febrile, and then he has a productive cough, and they suspect pneumonia. So the bipolar would be the chronic, the acute would be the cellulitis and the pneumonia that has been diagnosed. And then if that TB comes back, that would be considered more of a chronic because tuberculosis goes into remission and then there could be exacerbations. Okay. All right, guys. So let's keep moving along. Stages of illness behavior. So illness behavior, there are 4 stages listed in the book. There's stage 1, experiencing symptoms, stage 2, assuming the sick role, stage 3, assuming a dependent role, and then stage 4, achieving recovery and rehabilitation. So really the name of the stage essentially kind of tells you what occurs in each of those stages, and we're going to talk about these in a little more detail as we move forward. So let's look at stage 1. That's experiencing symptoms. So if you could think about, whenever you've been sick, what symptoms did you have? Maybe it started as a tickle in your throat, and then your throat got a little more sore, and then you started having a runny nose, and then you started to have a headache. So you can kind of think about what is, but some people would blow that off and say, oh, it's just allergies, or it's nothing, or I'm not really sick. So how do people define themselves as sick? What is sickness to that person, right? Maybe they're recognizing one or more symptoms that are compatible with their own definition of health. If the symptoms last for a short time or relieved by self-care, the person usually takes no further action. So maybe it is allergies. Maybe that tickle in their throat, the sore throat, the runny nose, the headache are all related to seasonal allergies or environmental changes. But if they continue, the person enters the next stage. So stage 2 is assuming the sick role. Now we're going to seek validation of this experience from others. Maybe they, go see a doctor and they say, you know what, I want some validation, to say that I'm sick. Do some tests, look in my throat, look in my ears, whatever else. Give up normal activities. They might start to assume a sick role. They're taking it easy. They're not doing as much. Maybe they take a sick day at work if necessary. They focus on their symptoms and their bodily functions. So instead of, being able to focus on other things, maybe they start to go, gosh, these symptoms, my runny nose, my throat hurts more, I have a headache, I can't focus. So they start to kind of think about those more. Then in stage 3, there's assuming a dependent role. That's when they accept the diagnosis and follow the treatment plan. So maybe the doctor says, you know what, you have a little bit of a, maybe, I don't know, upper respiratory infection, or maybe they have something going on with their sinuses or whatnot. They might then, have to take antibiotics, or maybe they're just taking some over-the-counter, allergy medication, kind of whatever the treatment plan is for that patient, that's what they'll follow. And then stage 4, achieving recovery and rehabilitation. That might begin in the hospital and conclude at home, or if they're at home, it would just be at home that they're recovering, they resume normal activities. So people don't fully recover or rehabilitate while they're in the hospital, depending on what they have. They might have to go home and continue that process, okay? And they conclude that at home. So a person who is experiencing a productive cough and fever takes a sick day to recuperate and decide whether to make an appointment with the doctor. This person is said to be in stage 3 of illness behavior, assuming a dependent role. All right, guys. So what do you think, true or false? Let's look at the answer. The answer is actually false, guys. A person who defines oneself as sick and self-medicates or visits a doctor is said to be in stage 2 of illness behavior, assuming the sick role. Okay, that's when you start to kind of let those symptoms kind of progress. They start to bother you more. You start to kind of take it easy more, see a doctor, figure out what's going on, get some validation, and then you move into stage 3 where you start to work on the treatment. Okay? All right, guys, so let's talk about factors influencing health disparities. Health disparity basically refers to um, essentially a higher burden of illness, injury, disability, or mortality by one group relative to another. Okay, so one group might have more health disparities than another, and it's related to a lot of things. It's related to both modifiable and non modifiable factors, such as racial and ethnic group, poverty, gender or age, mental health, educational level, disability, sexual orientation, or health insurance and access to health care. So if somebody is, um, if they live in poverty, or they're part of a specific ethnic group, that they maybe don't get the health benefits that others get. Maybe their health insurance doesn't cover it, or they don't have health insurance. Maybe they have a disability. So all of those things you have to think about do influence health disparities. So it's, basically a thought of, equitability. Is it equitable? Are people getting equitable opportunities to have, the same type of really healthcare and health promotion and wellness? So let's look at the modifiable risk factors. Modifiable risk factors, those are things we can change. If a group is known to have issues with diabetes, or it's more known within that ethnic group, then that's something they can definitely focus on trying to change. If there's dietary problems or high blood pressure or obesity, those are all modifiable things. Non modifiable, you can't change your ethnicity, you can't change your age, your gender, or your family history. So those are things that impact somebody's health disparity, but cannot be changed by that person, right? So we might know that a certain group has higher risk for high blood pressure or heart disease or diabetes, but we can't change the fact that they're part of that group. We can just change the factors that maybe lead to having those problems, and maybe we can help them with those and promote health practices that would help reduce their risk of developing diabetes, high blood pressure, or cardiac problems. All right, so true or false? An example of a health disparity is the higher incidence of diabetes in the African American and Hispanic population compared to the white population. True or false? It's actually considered true. Okay, so we know that health disparity, that we do know, looking back, that there is a higher incidence of diabetes in those groups. And some things are modifiable and other things are not, like the fact, the ethnicity, the ethnic group that they're in, or the age. Remember, those are non-modifiable. However, there are some things that we can work with on individuals within that group or that population. Okay, so moving on. Factors affecting health and illness. There are a couple things that go into health and illness of a patient. Basic human needs, those must be met for emotional and physiological health and survival, right? When needs are met, may be considered to be healthy. When a person has one or more unmet needs, it is increased risk for illness. So if somebody doesn't have their physical needs met, then it's more likely that they're going to have increased risk for illness. So for example, if somebody lives in poverty or is, homeless, and they have poor nutritional habits because they don't have money to buy food or nutritional food, then they are at increased risk for illnesses that go along with nutritional deficits, right? Then we have something like human dimensions. We have dimensions of the human body: physical, emotional, intellectual, environmental, sociocultural, and spiritual. Those can affect health as well. So if somebody feels imbalanced in their, maybe spiritual or emotional state or dimension, that might impact their risk for illness as well. And then concepts such as self-image and body image, those also have to do with someone's feeling of a feeling of health, right? Because remember, health kind of encompasses all the parts of our body. It's very holistic. It's not only that we have physical health, but do we have, psychosocial health and emotional health and things like that. It all kind of goes along, okay, with the human body, okay? And this kind of relates to Maslow's hierarchy of needs, right? Because the bottom level of Maslow's is the basic needs, food, water, shelter, things like that. And then as you move up his pyramid, you start to see some of those other things like emotional, intellectual, sociocultural, and spiritual type health. And then, as you move towards the top even more, you get that self-esteem and body image. So let's look at the different levels of prevention for our patients, okay? So there's 3 levels of prevention. Those are primary, secondary, and tertiary. Primary prevention is directed toward promoting health and preventing the development of disease processes or injury. Examples: immunizations, family planning, poison control, accident prevention, even encouraging people to wear safety gear when riding, bikes or motorcycles or anything like that. So all of these things are going to help to prevent the development of disease. So we take immunizations so that way we don't get a disease that is known to be caused, or you're at greater risk if you don't have the immunization, right? And then secondary is going to focus on screening for early detection of a disease with prompt diagnosis and treatment for any found. So examples are assessing children for normal growth and development, encouraging regular medical, dental, and vision exams. So we do those screenings in order to essentially, detect those problems early, because when we have early detection, it's much easier to treat, right? Depending on, how advanced it is when we find it. So if we find that a child is having abnormal growth and development, we can start to look at why before maybe it causes additional, concerns for them. Or when we go for our dental checkups, making sure that we get, any problems identified early and screened early so that we don't have additional problems, right? And that we can treat it early instead of having it get complicated or complex. And then we have our last level of prevention, which is our tertiary. This begins after an illness is diagnosed and treated with the goal of reducing disability and helping rehabilitate patients to maximize level of functioning. So examples include teaching a patient with diabetes how to recognize and prevent complications, using physical therapy to prevent contractures in a patient who's had a stroke or spinal cord injury, and referring a woman to a support group after removal of a breast because of cancer. So essentially, it's like the patient has had the disease, they're diagnosed, they're being treated. And part of the treatment is then helping them with this tertiary level in order to promote the maximum level of functioning. Okay, so somebody even with an amputation, they've had the amputation, we're at the tertiary level at this point, but there are things we can do to help rehabilitate that patient so they can get back to their maximum level of functioning, which won't be the same as what it was before the amputation, but it can definitely get them closer to where they are now, right? Okay, so those are the 3 examples. So primary, secondary, tertiary. So let's look at a question here. What is an example of a nursing activity that promotes secondary prevention as a level of preventative care? Would it be A, conducting a smoking cessation class, B, performing a blood pressure screening at a local mall, C, performing range of motion exercises on a bedridden patient, or D, promoting safer sex practices in school settings? All right, so let's see the answer, guys. It actually is B, performing a blood pressure screening at a local mall. Remember, guys, secondary prevention focuses on early detection of disease, such as heart disease in this example. Primary preventative care is directed toward promoting health and preventing disease. Tertiary care begins after an illness is diagnosed to reduce disability and rehabilitate patients. Okay. All right, so let's keep going. Another question here. You will use the concept of primary prevention when instructing a patient to A, get a flu shot every year, B, take a blood pressure reading every day, C, explore hiring a patient with known disability, or D, undergo physical therapy following basically a stroke or a cerebrovascular accident. Which one would be primary? All right, so if you guys said A, get a flu shot every year, that is a form of primary prevention, will decrease the risk of illness from the disease. Okay, so remember, guys, primary is more preventative. So we're preventing. We know that the flu goes around. We know it's an issue. So if you get your flu shot, then it's less likely that you'll get it. And if you do get it, you'll have a decreased risk of maybe it'll also be decreased in the severity. Okay, so decreased risk and decreased severity if you do end up getting it. All right, so wellness and health models. We're going to look at 4 different wellness and health models in this course. And as you move through the program and you progress, you'll learn about some additional ones that maybe focus more on, children, or when you're in mental health, you might focus more on, psychosocial type models. Some of these incorporate some of those things, such as age and psychological focus, but you'll start to work with those a little bit more as you progress through the program. So let's look at these 4 models in a little bit greater detail. So you have this health belief model. Health belief model is basically in the middle there, you're seeing that they have a perceived benefit versus perceived barriers. Okay, they have a perceived threat, self-efficacy, and cues to action. So you have those 4 things there, which is part of that health belief model. Then it is believed that you can see over here in the modifiable variables, those impact these 3 things here, right? So we have modifiable variables that we can modify in order to, kind of impact these 3 areas. Then we have perceived seriousness and perceived susceptibility, and that kind of leads into this perceived threat. And then these leading into these that then lead into this is likelihood of engaging in health promoting behaviors. So you kind of have to think about these things. So does a person see themselves as getting sick? Do they see the threat? Do they see the benefits versus the barriers? And do they see the self-efficacy and the cues to action is what's going to kind of drive them to get more of the help, right? To engage in those health promoting behaviors. So an example that I think about is something like when somebody, smokes. We know that smoking can cause lung cancer. It's proven by studies, right? But then you have to say, then why do people continue to smoke? And that's always kind of a mind-boggling thought. And those that do smoke, a lot of times they may not see the benefit over the barriers. So they feel like they need to smoke. They feel like they need to have that, right? But they don't see the benefits of stopping. They also might not see the perceived threat, like, oh, well, my mom or my grandfather or my grandmother smoked for, as long as I can remember, and they never had any problem, right? So they don't see a threat there. And then, so then they're not necessarily going to maybe, think that it's a serious or they're susceptible, so they don't make any changes. And oftentimes it's not until the patient actually gets sick with something that they actually see the threat, okay, or the seriousness of it. So oftentimes it takes that patient getting sick in order to change the way that they're doing things and actually start engaging in those health promoting behaviors. So let's look at the next. And we can look at this a little greater. I put this in here. Do they, like I said, does the individual believe they have? What chance do they have of getting the condition? Maybe they think about their family that never got sick from smoking. How serious individuals believe a certain condition will affect their life situation. Maybe they had someone in their family get lung cancer and they survived, and they think, even if I get it, I'll be the same, right? Then the benefits versus barriers. Do they see benefits if they take health action? If they take action in addressing the health condition. So do they see that their life could be better without the smoking, or do they still feel like they need the smoking in order to fulfill something in their life? Okay. And then barriers, the roadblocks or threats individuals anticipate in trying to address the health condition. Well, somebody who smokes, maybe they do it for whatever reason, so they see that they might continue to have those issues, or those are going to become even worse if they don't continue the practice that they're doing. And then cues to action, external or internal factors that stimulate the individual to act, and then self-efficacy, the level of confidence individuals have in their ability to act. So, you'll often hear patients say, like, I just can't do that. I can't stop smoking. I've smoked for 30 years. And it's really an addiction, right? So it's hard for people to change something that they've been doing for a long time. Do they think that they have confidence in themselves in doing that? And that's where we come into play as healthcare providers, really building their confidence and working with them every step of the way so that they can be successful. And then the health promotion model, this is our second model. Developed to illustrate how people interact with their environment as they pursue health, incorporates individual characteristics and experiences and behavior specific knowledge and beliefs to motivate those health promoting behaviors. There's personal, biologic, psychological, and sociocultural factors. Those are predictive of a certain health related habit. And then health related behavior is the outcome of the model and is directed toward attaining positive health outcomes and experiences throughout the lifespan. So let's look at this here. So you can see individual on the left here. These boxes are individual characteristics and experiences. Prior related behavior, maybe some personal factors. Remember, we talked about it said that the biological, psychological, and sociocultural factors come into play. Then we look at how it leads into, do they have a perceived benefit of action, perceived barrier, perceived self efficacy, and activity related effect? Kind of sounds similar to the last one we talked about, right? And then interpersonal influences, family, peers, providers, norms, supports, models. And then situational influences like the environment, right? Which is options, demand characteristics, aesthetics. So some of these things look at the psychological, biological, and sociocultural issues. And then that leads into commitment to a plan of action and health promoting behavior. And then you have some immediate competing demands, right? So there's some controls that might come into play there that take over or might impact the health promoting behavior. But truly, once the patient decides that they want to make the change, they make a committed plan of action, then they start to do those health promoting behaviors. Okay, so this just looks at how, there's environmental factors, support systems, sociocultural norms, and things like that that all impact, right, their commitment to change. Okay, they also have to believe in it. They also have to see the benefit, talk about the barriers, remember the confidence and the activity related effect. Okay, so they have to see all of that in order to want to make the change. The agent host environment model, this is the third one. This views the interaction between an external agent, a susceptible host, and the environment as cause of a disease in a person. You can see on the side here that kind of goes into it. All three of these things overlap and they all affect one another. It is a traditional model that explains how certain factors place some people at risk for an infectious disease. The three factors are constantly interacting, and a combination of factors may increase the risk of illness. The use of this model is limited when dealing with non-infectious diseases. So basically, there are environmental factors that are going to affect the whatever's causing the problem and the host, and then you have the transmission between the agent and the host. So this looks at the three things interacting with one another in order to identify when patients will be at risk for those problems. Okay. All right, guys, so this model, the health illness continuum, is basically conceptualizes a person's level of health, views health as a constantly changing state with high level on one end, and on the opposite end of the spectrum, death. Okay, and then you see that in between there's illness, normal health, and good health. Okay, and it's ever changing. So maybe sometimes there's normal health here, and then they fall into the illness state because they have, maybe an acute illness, and then they go back to normal health, and then maybe they're in good health, and then, so it's kind of this balance, this back and forth. And it's often interesting to hear where where a patient views themselves on this continuum and then where the nurse views the patient on their continuum. So basically, it looks at, from illness towards health, where is the client? And that's where, you're kind of using this model. So if they have just say an infection and they're ill right here, and then once the infection goes away, they kind of creep closer to normal health, and then they're back into good health over here. So that's kind of just in a nutshell the health illness continuum. I think out of all of the models, I like this one the best because I feel like it is nice in seeing that visual of a patient's illness to normal health to good health, and they can kind of see themselves, and it's a nice visual for the patient as well. Whoops. Okay. Let's look at the stages of change model. So based on those models, remember a lot of them ended up in making a change, right? A lot of those models ended up with, okay, I believe I have a problem. I know it's, it's serious. I want to make a change before something really happens. So I'm going to go ahead and change the things I'm doing to be healthier in a healthier state, right? So then what this model does is this actually looks at the stages of change. So here there's 6 different box or circles, I guess you could say, and these are the stages of change. So what this looks at is the pre-contemplation. That's when maybe they're, you know, thinking about change, but there's no intention of changing the behavior. They've kind of started the process. They know that, maybe they need to lose weight, but they're not really, at the point that they're going to do anything right now. Okay. Or maybe they don't even think it's a problem right now. Okay. Until they start to see that it's affecting their overall health. Then they start to go, okay, there's a problem. I'm aware there's a problem with my weight. It exists, but I'm still like not really ready to do anything, right? Then I get into the preparation phase where I go, okay, I really need to start, watching my weight. I really need to start thinking about my weight. I'm going to start preparing. I'm going to start kind of making a plan. This is where you're getting buy-in from that patient. Okay, they're convinced that they need to make this change, and they believe they can. You've talked them, into it in a good way. Not that you should ever talk a patient into something, but you've really gotten them to buy in, and you've gotten them to believe in themselves that they can do it. And then action. This is where they're going to start to really try. Okay, this is where they're going to put their plan into action. They're actively modifying that behavior. So maybe they're on a dietary plan and they've met with a nutritionist, and they have a goal. They've set goals, and they have you know plans on what they're going to eat for every meal, and they're keeping a journal, and they're doing really, really well, and they're making that change. And then this maintenance is that they have to sustain the change, which is often the hardest part, right, guys? So we all know when you want to make a change in your life, it's really easy to make it, and it's easy to sustain it for a little bit of time. Everybody's really excited. Think about maybe a diet that you've done and you've seen results and you've lost weight, but then comes in the maintenance, right? And then you got to sustain it, and you got to make sure the new behavior replaces the old. And it's very easy to you relapse, which is the next box here, right? We fall back into our old patterns. Oh, I don't really have time to cook fresh meals. I don't really have time to go to the grocery store. I'm just going to go through a drive-through. It's much easier. I think we're all at that point, right? Right now. So then you relapse. You go back to the old behavior, and not because there's anything wrong with you, or whatnot, or there's anything wrong with your patient, but because it's very hard to maintain a change. Okay, it takes a lot of effort. Okay, so then you have to kind of make sure that they have that upward spiral, learn from each relapse, but we really need to help them with this maintenance stage. That's the one area that we really need to make sure that they really try to stay in. Okay, we don't want them to relapse. We don't ever want our patients to relapse, but sometimes it happens. Um, and hopefully the next time, like it says in the upward spiral, each time a person goes through the cycle, he or she learns from each relapse and hopefully grows stronger so that the relapse is shorter and less devastating. So if the relapse occurs, it happens, right? That's life. But maybe next time we'll make a change that is a little bit more sustainable. All right. So let's look at this. A nurse educator uses models of health and illness when teaching. Which model of health and illness places high level health and death on opposite ends of a graduated scale? Is it A, the health illness continuum, B, the agent host environment model, C, the health belief model, or D, the health promotion model? All right, if you said A, the health illness continuum, you're absolutely correct. Remember, we have health on one side, or high level of wellness, and then death on the opposite side. Remember, the agent host model is useful in examining the causes of disease. Remember, we have the agent, the host, and the environment. The health belief model describes health behaviors. The health promotion model incorporates individual characteristics, experiences, as well as behavior, specific knowledge, and beliefs to motivate healthy behavior. Okay. All right, guys. True or false, the agent host environment model of health views health as a constantly changing state, with high level wellness and death being on opposite ends of the scale. All right, that's false again, guys. Remember that health illness continuum. Sally has decided to set aside 30 minutes a day to walk after work next week. Sally is in what stage of risk factor modification? So think about those circles that we went over, the stages of change. What stage of change do you think she's in right now? A, pre-contemplation, B, contemplation, C, preparation, D, action, or E, maintenance. All right, if you said C, Sally's preparing to make the modification by planning to walk. So she's in the preparation, right? So if you go back and look, that was C, preparation. She's setting aside, has decided to set aside 30 minutes a day. Once she actually starts the walking, then she'll be in the action, right? And then she's got to maintain it. Okay, she can't do it for a couple weeks and then stop. She's got to keep doing it. Okay, so she was in the preparation. She's decided to, and that's always a good start. And then we got to put it into action. All right, guys. Well, that concludes the health and wellness lecture. You also learned about some, health models. And so take all of this information. Hopefully, you filled out your notes. Take some time to do that. And I'll see you guys soon.